Hi, and welcome to this presentation on the Cardiorespiratory Physiotherapy Problem List. In this presentation, we'll be introduced to the Cardiorespiratory Physiotherapy Problem List. We will examine each problem individually and discuss how to identify each one in your patients. This problem list is taken from the Pryor and Prasad 2008 text. There is a new edition now released in 2016 by Main and Dennehy, but it does not include how to identify these impairments in your patient. It also doesn't go over how to interpret chest x-rays or arterial blood gases, but it does have more up-to-date evidence in regards to the particular physiotherapy interventions, so is worth a look. So what are the cardiorespiratory physiotherapy impairments and why do you need to know them? When treating a patient's lungs, the signs and symptoms that you discover on your assessment can be used to identify if the patient has any specific cardiorespiratory impairments. Once you have identified evidence that they do, you can choose a treatment that you know is beneficial for the impairment identified. Often patients present with many different signs and symptoms, and it can be difficult to know where to start with your treatment. Creation of a problem list based on these impairments will give you a clear picture of what their main issues are and so what treatments to use to address them. You will learn more about this in the presentation on clinical reasoning in the cardiorespiratory patient. Some of these problems are more common than others, and some we can do more to help with than others. The other main advantage of using this approach is it makes it really easy to go back afterwards and reassess your treatment. If you had identified pain, then you would use the same measure you did to identify pain as an issue and reassess. Easy. No matter what situation you find yourself in clinical, if you can keep formulating an up-to-date problem list in your mind and you know what treatments work for each impairment, you will be successful in your intervention session. So let's explore these impairments. Pain is defined in the dictionary as a highly unpleasant physical sensation caused by illness or injury. We know that pain can be acute or it can be chronic, and it is a highly subjective experience that can only be appreciated by the person experiencing that pain. Pain is something that should never be overlooked in a patient. As physiotherapists, we are often the ones that identify an ongoing pain issue that prevents a patient from moving around or taking deep breaths and coughing. It is absolutely up to us to follow up on that with the medical team or acute pain service and then go back to see the patient. It is not a reason not to see a patient on that day, as a patient in pain is much more at risk of developing complications associated with positioning, being unable to take deep breaths, and being unable to mobilise. Pain is often a significant limiting factor in the performance of assessment and treatment techniques that we wish to apply as physios, and needs to be addressed as a priority in every patient. It is one of the first questions I will ask when I enter a patient's room. That way, if there's evidence that pain is an issue, you can address it early on. Then in the time the pain meds take to work, you can complete your subjective assessment and gather everything you need for your objective assessment and treatment, then the patient will be ready to go. We identify pain in our patients primarily by subjective report. Remember to quantify that pain score though. The numeric rating scale is probably easiest. If a patient is in significant discomfort, you may also find they are sweating, pale, have an abnormal breathing pattern, and in extreme pain, heart rate, respiratory rate and blood pressure could also be elevated. Reduced lung volumes for me correlates with a reduced passageway of air, making it difficult for the alveoli to participate in gas exchange. This can be due to a number of reasons. It can be due to an interruption in the mechanics of ventilation, for example, an inability to contract the diaphragm, expand the chest wall, or to expand the lung tissue. It can be due to increased resistance to flow of air into the lungs, for example, inhaled foreign bodies, retained secretions, or compression of the lungs by an external force, such as positioning, abdominal distension, pleural effusion, or pneumothorax. Or it can be due to altered control of ventilation, for example, damage to the respiratory control centre in the medulla, damage to the nerve pathways, or medications or anaesthetic agents. It is one of the most common impairments to appear on the cardiorespiratory physiotherapy problem list, particularly as it is a consequence of lying supine for prolonged periods and prolonged inactivity, which will be the case for many hospital inpatients. If not addressed, it can go on to contribute to the development of impaired airway clearance, impaired gas exchange, dyspnea, and reduced exercise tolerance. Reduced lung volumes can also be a secondary problem, particularly if the patient has abdominal and thoracic pain which prevent them from inspiring fully. So how do we determine if our patient has reduced lung volumes? Our most useful tool is auscultation, where we will hear reduced breath sounds. Remember though, if breath sounds are reduced globally throughout the lungs, it may be that the patient has hyperinflation or too much air in the lungs, not too little, in which case their main issue is likely airflow limitation rather than reduced lung volumes. They can get the air in okay, they just can't get the air out. More about that shortly. Palpation will reveal reduced expansion, and chest x-ray may show collapse, atelectasis, or another restrictive pathology. Spirometry testing will show a reduced FVC with a maintained FEV1 FVC ratio. Make sure you review the spirometry presentation if you're unfamiliar with the significance of this. The patient may also exhibit an increased respiratory rate and/or heart rate to compensate, but remember these can be caused by a number of issues and do not count as evidence that your patient has reduced lung volumes. Mucus is usually cleared from the lungs by the mucociliary clearance system. If you're unfamiliar with this, you need to review the presentation on respiratory physiology in Module 1. If the mucociliary clearance system is overwhelmed or impaired, an effective cough will be required to clear the lungs. Impairments in cough will result in mucus becoming stagnant in the lungs. The lungs are dark, warm, and moist, a perfect breeding ground for bacteria, so infection will develop. This will result in more mucus being formed and further overwhelming of the mucociliary clearance system. Reasons for ineffective cough include respiratory muscle weakness, abdominal muscle weakness, reduced consciousness, reduced cough reflex, reduced reserve volumes, airway narrowing, or pain. The consequences of impaired airway clearance include infection, reduced lung volumes due to sputum blocking the flow of air into the lungs. Consequently, impaired gas exchange, dyspnea, and reduced exercise tolerance may develop. So how do we know if our patient is having difficulty clearing secretions? Remember, the presence of secretions or a change in the nature of secretions do not necessarily mean the patient has impaired airway clearance. Airway clearance is only impaired if the patient is not able to clear it themselves. The patient may tell you they're having difficulty clearing their lungs. You might hear crackles on auscultation or feel fremitus on palpation. Fremitus being the vibrations felt resonating through the chest wall over where secretions are stuck in the lungs. A moist, ineffective cough and infiltrates on a chest x-ray are also indications that there are secretions being retained in the lungs. Impaired gas exchange will rarely occur in isolation, but is generally a consequence of other impairments. It is common in patients with respiratory or cardiovascular disorders and occurs as a consequence of shunt, which is a low VQ ratio due to a loss of ventilation, a high VQ ratio due to a loss of perfusion, a generalised hypoventilation, so generally caused by respiratory centre depressions or respiratory muscle weakness, or a decrease in FiO2, so altitude or malfunctioning of respiratory equipment, or finally it can be caused by diffusion impairment, so conditions such as emphysema, interstitial lung disease and reduced transit time of red blood cells, for example. You can get impaired gas exchange occurring when there is an imbalance between oxygen consumption and oxygen delivery as well. So if you have sepsis, fever, trauma, burns, anemia, low cardiac output, or in times of exercise, you may have more oxygen being consumed than actually can be delivered to the tissues. Remember though, when we're speaking about gas exchange, an increase in the partial pressure of carbon dioxide generally only occurs as a result of ventilation perfusion mismatches and hypoventilation. The result of impaired gas exchange is severe if left untreated and can result in ischemia, cell death, multi-organ failure and death of the organism. In terms of our impairment list, it will likely result in dyspnea and in reduced exercise tolerance. How do we know our patient has impaired gas exchange? Well, any use of oxygen therapy is a clue that gas exchange is impaired. For if they're requiring oxygen supplementation to maintain their oxygen saturations within a normal range, this shows gas exchange is impaired. Other signs include reduced oxygen saturation on pulse oximetry testing and a reduction in oxygen with or without an increase in carbon dioxide on arterial blood gases. Cyanosis tends to be a late sign of impaired gas exchange and signifies a significant impairment needing to be addressed emergently. The patient may, as a consequence, present with increased work of breathing, but remember there are many things that can cause increased work of breathing and it doesn't always present, so it cannot be used as direct evidence of a gas exchange impairment. So some signs of moderate hypoxemia are doubling in minute ventilation, tachypnea, restlessness, confusion, sweating, tachycardia, hypertension, pale skin and cyanosis. For severe hypoxemia, you might see bradycardia, arrhythmias, hypotension, blurred vision, tunnel vision, coordination loss, impaired judgment, convulsions, coma and brain damage. In situations of hypercapnia, the patient may experience warm peripheries, flushed skin, a bounding pulse, headaches, impaired concentration, drowsiness, convulsions, and coma. And in low carbon dioxide levels, hypocapnia, they might experience paresthesia in hands, face, and trunk, dizziness, loss of consciousness, visual disturbances, headache, tinnitus, ataxia, tremor, hypotension, or tachycardia. Dyspnea is not a term that is interchangeable with shortness of breath. Shortness of breath is a perfectly normal and sometimes even pleasant sensation that we all experience. Dyspnea is never pleasant. It is frightening and it is very unwelcome. It is sometimes referred to as air hunger. It is a subjective and totally individual experience. In acute clinical situations, the experience of dyspnea correlates closely with the level of physiological disturbance. But often in chronic conditions it does not align so well. For example, there might be a very small change in oxygen saturations but a very significant increase in the level of dyspnea, and this might be extremely disabling for the patient. Dyspnea can be a result of impaired gas exchange, reduced exercise tolerance, or respiratory or musculoskeletal dysfunction. It is important to remember also with dyspnea that anxiety is usually a feature, and although not a direct cause, will exacerbate the symptoms. It is crucial to tackle dyspnea in your patients. It is a cause of extreme psychological distress and will impair quality of life. It can also result in respiratory muscle and generalised deconditioning via avoidance behaviours, and musculoskeletal dysfunction can occur due to the postures adopted as a consequence of the dyspnea. The main way of identifying dyspnea in your patient is by patient report, and you should always get the patient to quantify this on the Borg dyspnea scale, or at the very least on a numeric rating scale. Get values for rest and on exertion. The patient may also complain of chest tightness. They may be unable to talk in full sentences and show an increased work of breathing, including accessory muscle use. You might also see the patient pursed lip breathing, which we will talk about more in our interventions presentation. Reduced exercise tolerance can be a consequence of other impairments, or it can be a direct result of disease process or general deconditioning. It has significant consequences, with patients demonstrating a reduced exercise tolerance succumbing to existing conditions sooner and being more predisposed to other conditions such as hypertension, atherosclerosis and diabetes. The patient will report being limited in certain activities. What is really important when establishing exercise tolerance limitations is to find out what is most limiting the patient. It may not be their breathlessness that is limiting them the most. They may have claudication pain or arthritis, which is preventing them exercising more. In that case, they need to be referred into the correct program to manage those symptoms. For example, a claudication exercise class or a hydrotherapy program for their arthritis. Also make sure you quantify their symptoms. I would suggest using the Borg RPE or dyspnea scales to find out the level of their symptoms on exertion. Exercise tolerance can be measured directly, and this exercise testing makes a great outcome measure that is used in many rehab programs. The 6-minute walk test, incremental shuttle, and cycle ergometry are examples of standardized exercise tests that physiotherapists use frequently. Respiratory muscle dysfunction is defined as a lack of strength or endurance of the inspiratory or expiratory muscles of ventilation. It is often very advanced before clinical symptoms are present. Causes include neuromuscular disease, connective tissue disorders, chronic lung disease, chest wall disorders, abdominal and thoracic surgery, oral corticosteroids, and malnourishment. After surgery, diaphragmatic excursion is reduced due to pain-reducing vital capacity, reflex inhibition of the phrenic nerve neuropraxia, which is a mild nerve injury which can follow cardiac surgery, or the altered breathing pattern after abdominal surgery due to splinting of the abdomen. These factors are likely to resolve spontaneously with time, but are likely to increase the risk of developing postoperative pulmonary complications. An existence of respiratory muscle dysfunction is likely to contribute to reduced lung volumes, impaired gas exchange, dyspnea, and reduced exercise tolerance. The best way to determine if a patient has reduced respiratory muscle strength is via a direct measure of maximal inspiratory pressure, but generally this can only be done in a pulmonary lab. Spirometry will often identify impairments in vital capacity and peak cough flow. Patients might report being breathless, particularly when supine, and in cases of profound weakness they will have an obviously altered breathing pattern. Airflow limitation is an abnormal resistance to airflow in the lungs, most commonly on expiration. It may be reversible, partly reversible, or irreversible with medications. Causes include obstruction in the airways, changes in the airway wall, or changes outside the airway wall compressing on the airways. Being unable to rid your lungs of air due to resistance of flow leads to hyperinflation of the lungs. More air can get in than can get out, and the air gets trapped in the lungs. This gets worse with exertion when the expiration phase is shortened, but the tidal volumes are bigger. More and more air gets trapped, and this is termed dynamic hyperinflation. This generally will reduce back to baseline over time with rest. This will result in impaired gas exchange, dyspnea, decreased exercise tolerance, and impaired airway clearance. The resistance to airflow reduces effectiveness of forced expiratory maneuvers to clear the airway of secretions, and the hyperinflation of the lungs depletes the reserve volumes, resulting in a reduced tolerance to exercise. The best way to identify airflow limitation in your patient is spirometry testing, where you will find a reduced forced expiratory ratio. You may also hear a wheeze on auscultation, and palpation will reveal a barrel chest and a loss of bucket handle, pump handle motion of the chest wall. The chest x-ray might also reveal hyperinflation, with horizontal ribs, flattened diaphragm, large lung fields, and a long skinny mediastinum. On observation, you are likely to see a barrel-shaped chest, pursed lip breathing, and a prolonged expiratory phase of breathing. Dysfunctional breathing, although it will be seen in almost every patient who has impairments on the problem list, is rarely used as a problem because we do not apply treatments to change a breathing pattern that is compensating for another problem. Only impairments that you are going to apply treatments to go on the list. Pure dysfunctional breathing is a complex disorder with significant psychological contribution. It presents with excessive sighing or breath holding, changes in inspiratory and expiratory ratio, chest wall movement abnormalities, and overuse of accessory muscles. Hypocapnia might appear on blood gases due to hyperventilation. If you suspect dysfunctional breathing, the Nijmegen questionnaire might be a useful tool to confirm your suspicions. It can be found easily on Google, spelled Nijmegen. Musculoskeletal dysfunction is a common consequence or contributor to cardiorespiratory disease. Examples of musculoskeletal dysfunction include congenital disorders such as kyphosis, kyphoscoliosis, and spina bifida. It might be due to poor posture from environmental or ergonomic factors, or could be secondary to respiratory or neuromuscular disease and dysfunction. Think about the patient who's always breathless and always coughing. They are likely to adopt a hunched posture, with increased thoracic kyphosis and shortened pecs. Bone mineral density deficiencies can cause changes to the spine, causing postural abnormalities, as well as contractures and trauma. Chest wall stiffness and poor posture will inhibit the chest wall from expanding as necessary to create the pressure changes required for inspiration. If you have a patient with a chronic obstructive disease and don't address postural changes, then you are going to have a restrictive disorder on top of their obstructive disorder. I cannot emphasize enough the importance of including musculoskeletal assessment and treatment into your cardiorespiratory patient plan. A really important thing to remember is that chronic coughing can cause or worsen pelvic floor dysfunction. All chronic respiratory patients should be screened for incontinence. If they indicate they do have problems with incontinence, they should be referred on to a gender health specialist physiotherapist. And if they do not have issues already, they should be provided with education and taught how to turn the pelvic floor on whenever they cough. Now we know how to assess our patient and how to identify from those assessment findings what cardiorespiratory impairments our patient might have. Now we need to take that information and put it into a treatment plan. The way we do that is by formulation of a prioritised problem list, and then matching our interventions to those problems. We talk through how to do that in our next presentation, Clinically Reasoning the Cardiorespiratory Physiotherapy Patient.